Most people fail this on the exam because, well, their instinct is always to treat. But the board wants to know exactly when you shouldn't.
Exactly. It's a huge trap.
Right. I mean, imagine you have a client who suddenly starts screaming whenever they are fed solid foods. You throw every behavioral intervention at the wall, shaping, differential reinforcement, token economies, and absolutely nothing works.
Which is incredibly frustrating for any clinician.
Oh, 100%. So, welcome to the deep dive. Today we are unpacking BCBA 6th edition task list domain F7. Our mission here is to give you board exam mastery and clinical authority on a topic that trips up even the most seasoned test takers, which is clinical decision making.
Right. Specifically that choice to treat or refer.
Yes, and we are analyzing a stack of specialized sources today. We've got BCBA mock exams, the ethics code for behavior analysts, and the latest advanced study guides.
And we are really looking at the exact scenarios that separate a novice from an elite, safe clinician. Because, our entire training conditions us to look at the environment.
Right. We analyze antecedents, we track consequences.
Yeah, and we immediately build a plan. That reflex to intervene is exactly what domain F7 is testing.
Okay, let's unpack this. That reflex is just so deeply ingrained in the culture of our field.
Oh, absolutely.
You see the problem behavior, and your brain immediately starts running a functional assessment in the background. Like you can't even help it.
Yeah, you're looking for the maintaining variable right away.
But domain F7 forces us to interpret assessment data to determine if we even need behavior analytic services or if we need to, refer out.
Which is critical.
Yeah.
It is the board's way of ensuring we remember that an organism is biological first.
Biological first. I love that.
Yeah, and that brings us straight to Ethics Code 2.1, which is considering medical needs.
Right. The code states that if there's any reasonable likelihood that a behavior is influenced by medical or biological variables, we have to ensure those needs are assessed first.
And any reasonable likelihood is the operating phrase there.
It's a pretty low bar, isn't it?
It is. It sets a deliberately low threshold for suspicion. It roots us firmly in the scientific concept of parsimony.
Meaning the simplest explanation.
Exactly. We must look for the simplest, most logical explanation before assuming some complex environmental contingency.
Right. So if a child is repeatedly slapping the side of their head, a behavioral clinician might immediately hypothesize an escape maintained or maybe an attention maintained function.
Yeah, but parsimony demands we stop and ask if they simply have an earache.
Which makes total sense. I mean, if it is an earache, no token economy or extinction procedure is going to fix that underlying infection.
No, it won't. And going back to that solid food scenario you mentioned earlier.
Oh, right. The screaming when eating.
Yeah, if a behavior isn't responding to a conceptually systematic behavioral intervention, that lack of improvement is a massive flashing red light.
Right. It's telling you something is wrong with your hypothesis.
Exactly. The client might literally be experiencing physical pain during swallowing, like severe esophagitis.
Oh, wow. So increasing the magnitude of a reinforcer in that situation isn't just ineffective, it borders on cruel.
It really does. What's fascinating here is how often practitioners ignore the biological hardware because they are so hyper-focused on behavioral data.
Which makes an immediate referral to a physician the only ethical move there.
Right. And the sources highlight another scenario in the mock exams that illustrates this beautifully.
Oh, lay it on me.
So you have a client exhibiting a sudden onset of problem behavior. There are zero environmental changes, no new demands, no staff turnover.
Okay.
But the behavior is accompanied by a rash and a sudden loss of appetite.
Oh, that's such a good example. It's like trying to fix a check engine light by reprogramming the car's computer when the engine actually just needs oil.
That is a perfect analogy.
Yeah, you have to fix the biological hardware before addressing the behavioral software, right?
Yeah.
You cannot operationally define a rash out of existence.
No, you absolutely cannot. The fascinating mechanism here is how physiological pain renders our environmental data utterly useless.
Because it's a completely different variable.
Exactly. I mean, we are conditioned to track ABC data. But if the true antecedent is internal, such as, gastrointestinal distress, our external environmental data will be entirely misleading.
Because it looks like it's connected to the environment when it's not.
Right. You might see a correlation with the task demand, but that demand is merely the final stressor for a client already in agony.
That reliance on environmental data leads directly into a major trap on the exam.
Oh, absolutely. The overconfidence trap.
Yeah, because applied behavior analysis is so incredibly effective, we sometimes develop this dangerous overconfidence that it applies to literally everything.
We think we can treat it all.
Right. And the mock exams feature a scenario where you are providing social skills treatment for a client, and you find out she was suddenly arrested for heroin possession.
Oh, that's a heavy one.
It is. And the exam will invariably offer a distractor option like intervene to decrease your client's use of drugs.
And a highly motivated candidate looks at that and thinks, well, drug use is operant behavior. It is maintained by immediate reinforcement, so of course we can treat it.
Yeah, I can totally see how someone could justify that using, like, the matching law or concurrent schedules of reinforcement.
Exactly. They think they just need to make the alternative behaviors more reinforcing than the drug.
But attempting to treat severe substance abuse as a solo practitioner feels like a massive boundary violation.
Because it is. We're dealing with severe physiological dependence and the potential for lethal withdrawal.
Right, you can't just token economy your way out of physical withdrawal.
No, treating a heroin addiction requires a highly specialized, multidisciplinary medical and psychiatric team.
Even though the principles of behavior do apply, right?
Well, they absolutely apply to addiction, which is why contingency management is utilized in rehab facilities.
Right, but the medical side comes first.
Exactly. The medical detoxification must take precedence. The physiological hijacking of the brain's reward system cannot be outcompeted by a standard behavioral contract in a community setting.
That makes total sense.
Your role is not to play the hero, It is to refer the client to an addiction specialist.
Right, but that boundary of competence is tricky, though.
How so?
Well, what happens when it is not a severe medical emergency like addiction, but rather an educational setting where a teacher is begging you to translate a child's psychiatric file?
Yes. The translator trap.
Yeah, because the instinct there is to be helpful and collaborative.
Of course it is.
The sources set up this scenario where a teacher calls you about a student, and as part of your preliminary intake, they ask you to explain the child's recent psychiatric diagnoses.
And what's your first instinct?
I mean, my first instinct as an analyst is to pull out the DSM-5 notes and break down intermittent explosive disorder for them so we are all on the same page.
And that is exactly what the exam wants you to do, so you get it wrong.
Wait, really?
Yes, stepping into that role shifts you from a behavioral model into a medical model that you are not licensed to practice.
Oh, I see.
Yeah, as behavior analysts, reviewing medical and educational records is a standard part of our initial intake. We need to understand the client's history.
But we don't interpret it for others.
Exactly. Interpreting or explaining psychiatric pathology to a third party is the explicit domain of a medical professional or a clinical psychologist.
So what do we do instead when the teacher asks?
We translate the label into observable, measurable actions rather than explaining the pathology.
Oh, so if the teacher brings up a specific diagnosis, we pivot the conversation to operational definitions.
Exactly. We ask what that looks like in the classroom.
Right, what happens right before the desk gets flipped and how often it occurs.
Yes, we keep the focus entirely on the environmental contingencies we can observe and measure.
That is such a crucial distinction.
It really is. And, another area where practitioners frequently step out of bounds involves how they handle the actual referral process once they determine a client needs outside help.
Ah, right. This falls under Ethics Code 3.13, which deals with unethical referrals.
Correct.
Okay, let's say I realize a client desperately needs a speech-language pathologist, and I happen to have a good friend who is a fantastic SLP.
Okay, sounds good so far.
But she is so fantastic, in fact, that she gives me a financial kickback, like a finder's fee, every time I send a client her way.
Uh-oh.
Right? It feels like a win-win on the surface. The client gets a great service, and I get a bonus.
Yeah, but the ethical fallout from that arrangement is severe.
Because of the conflict of interest?
Exactly. The ethics code mandates that when you make a referral, you must provide multiple options to the client whenever they're available.
Right. Funneling clients to one specific provider for personal financial gain creates a massive conflict of interest.
Your clinical judgment on whether a client even needs an SLP becomes completely compromised by the financial incentive.
Because you might just be looking for that bonus.
Exactly.
So what does this all mean for the listener taking the exam?
Well, you have to explicitly disclose any relationships you have with potential providers to the client, along with any fees or incentives, and document the entire process.
The transparency has to be absolute.
100% absolute.
So when a listener is sitting down staring at a 175-question test, they really need to spot these ethical and clinical boundaries instantly. They need elite pattern recognition.
They do. The board exams are heavily weighted toward testing your ability to spot specific conditional data patterns.
Like an if this, then choose this kind of strategy.
Exactly. So, Rule 1. The exam will present a scenario describing a sudden escalation of behavior, explicitly noting there have been no environmental changes.
Okay.
Or it will list physical symptoms like bruising, sudden sleep issues, gastrointestinal problems, or a rash.
Got it. And in those instances, your answer will almost always be to refer to a medical professional or rule out medical variables.
Yes. You do not select the distractor option to conduct an FA or implement extinction, because parsimony dictates we check the biological hardware first.
Check the hardware, right. What's the next pattern?
Rule 2 involves the limits of our own competence. We all want to fix the problem, but the scenario might state that a client's problem behavior is clearly beyond your personal expertise.
Right, like the severe addiction scenario.
Yes. Or perhaps the client's data is flatlining despite you making plan changes, ensuring perfect treatment fidelity, and conducting parent training.
Oh, that's tough. The ego trap there is to just keep tweaking the plan indefinitely.
Sunk cost fallacy is very real in clinical practice.
Yeah. You put so much effort into a plan that you cannot bear to admit it is not working.
But if the data shows no progress, despite perfect implementation, continuing to bill for ineffective services is unethical.
So you must choose the answer that directs you to refer to another behavior analyst or terminate services following appropriate transition measures.
Exactly. The data does not lie.
Never does.
And speaking of data, there's a very high-level trap regarding functional analysis. That's Rule 3.
Oh, tell me about this one.
If you are looking at an undifferentiated FA graph where the data paths are overlapping and flat across all conditions, the board is testing a very specific clinical interpretation.
That visual is terrifying for a novice.
It really is.
You see the behavior occurring at a steady rate in the demand condition, the attention condition, the play condition, and the alone condition. The immediate imposter syndrome response is to assume you just botched the assessment.
Right. Novices always assume human error. But if the behavior is happening, regardless whether you place a demand, give them a toy, provide attention, or leave them completely alone, it means the external environment isn't controlling the behavior.
The reinforcement is internal, it feels good, or it relieves pain, pointing directly to automatic reinforcement.
Yes, but identifying automatic reinforcement is only the first step.
What's the next step?
The critical mechanism the exam tests is whether you recognize that automatic reinforcement often masks physical pain.
Oh, I see.
Pressing forcefully on the head might be automatically reinforcing because it temporarily relieves the internal pressure of a massive migraine.
If we connect this to the bigger picture, the board is testing if we know our boundaries. They are looking to certify safe clinicians, not heroes.
Exactly. They want safe clinicians.
They want to know that you can look at an undifferentiated graph, realize your behavioral tools are the wrong tools for the job, and confidently ask for medical help.
Which is such an important skill.
Here's where it gets really interesting, though. How does knowing when not to treat actually make you a top-tier clinician?
Well, advanced BCBAs understand that the absence of a clear environmental function is actually one of the most powerful assessment findings you can obtain.
Wait, really? The absence of a function is powerful?
Yes. Instead of panicking over an undifferentiated FA and throwing a generic token economy at the wall to see what sticks, an elite clinician uses that data.
So you take that data to the pediatrician and say, look, I have rigorously tested every environmental variable. This behavior is not socially mediated. We need to look internally.
Exactly. You are using the behavioral data to aggressively advocate for the client's medical needs.
That is incredible.
And consider the physiological harm of doing the opposite.
Yeah.
Imagine a client who is severely self-injuring because they have an impacted bowel.
Oh, that sounds awful.
They are in agonizing pain. If a practitioner misinterprets that as escape-maintained behavior and implements an extinction procedure, meaning physically preventing them from escaping the setting and ignoring the behavior, the outcome is horrific.
Yeah, you are subjecting a patient in acute medical distress to an arbitrary behavioral protocol.
Right.
You aren't just failing to help, you are actively increasing their suffering.
Exactly. Real clinical power is knowing when to step back. recognizing the limits of our science, and collaborating with an interdisciplinary team.
It completely shifts the perspective from, giving up to pursuing the right kind of help.
It really does. But, this raises an important question.
Okay, what is it?
The real world, however, is rarely as clean as a multiple choice exam.
Very true.
What happens when you have the undifferentiated data, you have the sudden onset of symptoms, and you know the behavior has a medical root, but the medical system fails the client?
Oh, wow. You send them to the doctor and the doctor just dismisses the concerns.
Right. Or the caregivers completely refuse to follow up with medical appointments.
You are caught in this impossible space where you cannot treat a medical issue behaviorally, but you also cannot just abandon a client who is in daily danger.
Exactly. Balancing your ethical boundary of competence with the urgent need for harm reduction in the client's daily life is the hardest tightrope to walk in applied practice.
I can't even imagine.
It requires intense collaboration, relentless advocacy, and meticulous documentation. You have to navigate those messy human elements while holding the line on your ethical code.
That is definitely something for all of us to chew on. If this helped you, follow behavioral intelligence Con Mara Sanchez. Share this episode with someone studying ABA and leave a comment. This is how we grow and how I keep creating high-level content for you.
And to take your clinical reasoning to the absolute highest level, visit Amethyst Therapy Services. It is your primary place to get elite exam prep, advanced clinical tools, and professional growth systems. Go to www.amethysttherapyservices.com or reach out directly at info@amethysttherapyservices.com.
Next time you're faced with a complex behavior, before you try to rewrite the software, take a step back and check the check engine light. Make sure the biological hardware is running smoothly before you ever start writing a behavior plan. Thank you for joining us on this deep dive into behavioral intelligence. We'll catch you next time.